Good evening, everyone. I'm Adil Barucha. I'm the president-elect of the American Neurogastroenterology and Motility Society. And it's a pleasure to introduce the moderators for today's symposium on Pearls of Wisdom for Electrogastrography. Both dear friends, Dr. David Kunkel, who is an associate clinical professor of medicine at the University of California in San Diego, where he helps direct the GI motility and physiology program. Dr. Kunkel's research focuses on gastrointestinal motility and disorders of gut-brain interactions. He's a co-investigator on several high-profile NIH-funded studies, including projects aimed at developing innovative treatment strategies for fecal incontinence and creating a wearable biosensor to monitor gastric myoelectrical activity. The other moderator is Dr. Jason Baker, who is the Senior Manager of Clinical Training and Education for ANMS Robotica, also uber talented, has a research portfolio that includes partnering with diverse investigators and interdisciplinary teams. He's really good at this. And these projects range from, all across the spectrum for clinical projects, pharmaceutical trials, and biomedical technology. And he's found a way to integrate his research portfolio with also his work that he does on behalf of ANMS. And we're very grateful both to him and to David Kunkel for all that they do to foster the activities of the societies. So with that, thank you again for joining us. We hope you're enjoying summer and getting some much needed time with your family. So I'll turn it over to David and Jason.
Thank you very much, Dr. Barucha. Very kind words. Very dear friend for a long time. Has helped me along my career for 2 decades. Thank you for everybody joining tonight. This is a blessing to co-moderate with a very dear friend, Dr. Kunkel. Known him as long and became good friends along the way. This is a real true blessing. But this is about the pearls of wisdom of EGG, something that's probably not done. We're hoping to do more as across the country for helping patients find the right pathway. So for intervention, I'll let Dr. Kunkel introduce our speaker tonight. But one thing moving forward, if you have any questions, there's a Q&A button on the bottom of the webinar page. Please put that in there, and Dr. Kunkel and I will circulate those during the Q&A portion. And thank you for everybody joining.
Thank you, Jason. Thank you, Adil, for your leadership. Happy Gastroparesis Awareness Month, everybody. And it's my pleasure to introduce Lourdes Cabili-Lopez, who's going to be presenting today on electrogastrography. Let me tell you a little bit about Lourdes. She works right in Beverly Hills at Cedars-Sinai Medical Center. She's been a nurse for over 30 years, and she's been with their esteemed GI motility program for 7 years. Lourdes is a trainer in electrogastrography and has been using a system biolimetry for 1.5 years. She recently won the Margaret Stempson Carter Award for recognition in nursing professionalism. And so it's my pleasure, Lourdes, to have you speak today, and we'll pass the mic over to you.
Thank you so much, Dr. Kunkel, for the kind words. And thank you, ANMS, for giving me this opportunity to talk about electrogastrography. Okay. Pearls of Wisdom, Electrogastrography. What is an electrogastrogram? Electrogastrography, or EGG, is a non-invasive method for recording gastric myoelectrical activity. EGG is done by placing electrodes on the skin over the stomach. There are multiple EGG options available. Depending on what EGG option you are using, each has their own specific equipment that they use to collect the data. The EGG measures electrical activity from the ICC, the pacemaker cells of the gut. The recording is called an electrogastrogram. These tests can be used for patients with upper abdominal pain, epigastric pain, abdominal bloating, early fullness, heartburn, nausea, and vomiting. This is a traditional EEG tracing. It's a normal EEG tracing, an example. And this is an example of the normal allimetry tracing. Pre-test preparation is patient is 6 hours NPO before the test. If they are diabetic, they should check with their providers. Also inform the patient that he or she will be in a reclined position. Legs should be slightly raised and allow abdominal muscles to fully relax during the test. We instruct patients to hold medications that may alter the rate of gastric emptying, such as metoclopramide, erythromycin, antispasmodics. Also instruct patients to hold opioid-containing medications for at least 2 days before the test, including codeine, morphine, oxycodone, and etc. Avoid sedatives and tranquilizers before the test. No laxatives the day before or any time during the test. We encourage patients to wear a loose top, bottoms for placement of electrodes or arrays. Avoid wearing bras with wireframes as the sensor may need to go underneath. We also tell patients to avoid moisturizers, lotion, and remove any abdominal piercings if they have. Excess body hair on the abdomen may need to be shaved in order for the array or the electrodes to stick and have a good conductivity. Ensure there is no open wounds, abrasions, or infected areas on the abdomen. Check allergies to adhesives or dietary restrictions. Thoroughly clean the skin. This is so important for this test. Apply a thin layer of electrode jelly or new prep gel to rub into the skin in a circular motion. This is essential for this test. These steps will exfoliate the skin and improve conductivity of the array. Once the skin prep is finished, it is essential that the excess gel is wiped off the skin with a clean cotton pad for the array to adhere. Then after that, once the array is there, position the patient in a comfortable position to minimize movement. We instruct patients to avoid talking, laughing, sleeping, and limit movements during the test. I also let the patient know that this is a 5-hour test. Placement of electrodes. We measure the xiphoid to the umbilicus, xiphoid to anterior superior iliac spine, and then the circumference. This will give us an idea on where to put the array. The fasting phrase, 30 minutes of recording is equal to the baseline when patient has been NPO. Then we give a test meal and allow 10 minutes to complete the meal. We always encourage patient to finish the whole meal, or at least 50% to consume the 50% of the meal. The test meal is to stimulate motility. Stimulation phrase, stimulation recording will be next. The common meal types for stimulation phrase is the standard is the Abbott Ensure or similar nutrient drink, which is 240 calories plus the Cliff bar or similar bar, which is 250 calories. For diabetic patients, we have Nutricia Diasep or similar drink plus Nestle OptiFast very low calorie diet bar or similar bar. We also have gluten-free, which is Abbott Ensure or similar drink times 2 Detour Smart bar or similar bar. We also have vegan for patients who are vegan, Abbott plant-based Ensure or similar drink plus a Clip bar or similar bar. The two main myoelectrical activity of the stomach is a slow waves, pace setter potential, or electrical control activity. Spike potentials, the action potentials, or electrical response activity. A gastric contraction occurs when a slow wave is accompanied by spike potentials. It is not uncommon to record gastric contractions when there is no spike potentials. This is an example of a common normal findings. And a common finding for bradygastria, which is 0.5 to 2.0 cycle per minute. This is a traditional EGG tracing comparable to allometry. So we have the tachygastria, allometry, tachygastria, example tracing. And the traditional EGG dysrhythmia and allometry dysrhythmia. Test instructions. Monitor for skin irritation, which is common and not to be alarmed. Symptoms are usually mild and self-limiting. It is common for skin to remain red for up to 72 hours after the test. If the swelling or other redness persists, advise always the patient to seek medical professionals. Okay to wash the area with soap and water and pat dry. Patients may resume routine medications and diet post-test. I also instruct the patient to schedule a follow-up visit with their provider to discuss results and a plan of care. Billing codes, CPT code 91132, that's what we've been using. Okay, pearls of wisdom for accurately performing an EGG. I usually call a patient a week before the appointment. I know that once they're scheduled, one of our PSR will let me know that there's a patient scheduled for a telemetry, for the EGG on a certain day. Then I put it on my calendar and call the patient a week before, give them instructions regarding, we review the MAR or the medications they're taking, and instruct patient to stop motility medications or any medications that can alter stomach motility ahead of time, usually 2 to 3 days before the test. I perform a physical examination to ensure that there is no skin breakdown, open sores, or inflammation during the test. Then when there's excessive hair, I shave it accurately and give specific instructions during the test to limit movement, allow patients a chance to use the restroom before applying the array or electrodes. And I also remind them to bring something to do or to read or watch a movie to make the few hours go by easier. Skin prep is essential to have to have an accurate result. It is essential that patients will be aware also to what to expect during the test to ensure that there's no surprises. Thank you.
Well, thank you, Lourdes. Thank you, Lourdes, for the detailed and excellent presentation on electrogastrograms. Maybe a bit dating myself, been around a while. There's a large percentage, I think, of the community may not have never done an EGG or been a part of an EGG. So thank you for providing all the instructions and the tracings of the EGGs. I got a few questions, actually. Throughout your presentations, I was writing down a few notes, and if anybody in the attendees have any questions, just put them in the Q&A box on the bottom, and Dr. Kunkel and I will circulate through those. But when you're doing an EGG, do you regularly annotate on the tracings? Like if someone is like having abdominal pain or nausea or any symptomology throughout the test, you annotate on there, so when the provider interprets the test, they can maybe provide a little bit more guidance of the spike potentials or the difference fluctuations in the tracings itself. So could you provide some guidance on when to annotate and maybe how to annotate and why to annotate?
Okay, the EGG option that we used allow us, there's an equipment that we use. I give them an iPad that they can tell what their symptoms are. This iPad beeps every 15 minutes and asks the patient to update their symptoms from 0 to 10. If during the test the patient vomits, then there is a thing on the iPad, on the app, that they have to hit that they vomited at that time. So it's accurately what time they vomit or their other symptoms they have. It's been noted on the iPad that we give the patient after we set them up.
Okay. And Dr. Kunkel, I just want to, maybe for the providers on the call, just when you're reviewing these, could you provide a little bit of guidance how those annotations are beneficial to your interpretation of the EGD?
Yeah, I think that's really important because one of the advantages of this technology is symptom association analysis. You know, we want to know these are patients with all kinds of symptoms, and we're looking to see, is there a connection here with electrical activity or muscle activity in the stomach? For example, if a patient experiences nausea during their EGG, was that when all of a sudden there were rhythm abnormalities that were picked up? Or was that when the amplitude was not increasing as it should with the meal? So it can really help establish a basis for whether a symptom is arising from the stomach or not. If a patient reports a very non-specific symptom that's humbling for all of us, bloating. If they're reporting bloating and there's no change at all in that EGG signal, it's stable, nothing's cooking, that's helpful. You know, clinically, that makes me a slightly less inclined to think that that symptom in that moment has a gastric origin. And that's also helpful to review with patients. Patients actually really like that symptom association analysis. So I think, Jason, you've honed in on a real important feature that Lourdes does, and that's key to any EGG protocol, which is documenting symptoms. At the end of the day, that's what we're trying to treat.
Okay.
So with
And
the EGG options that we use, doctor, once I set up the patient, it has 6 symptoms that they need to rate from 0 to 10. Bloating, abdominal pain, epigastric pain, fullness, nausea, and vomiting. So before, like after I set them up, before they even eat the meal, they already rate their symptoms from 0 to 10. Then this thing beeps every 15 minutes and asks the patient to reevaluate their symptoms from 0 to 10. So right after I set up the patient, they're on their own. Like I only have to check them every 40 minutes to see if they need anything. I have a call light next to them if they need to have symptoms. And if they move too much, this thing will remind them to, okay, you're moving too much. So I put that also on my notes at the end before I upload the thing.
And we got a question from anonymous attendee. I'm probably going to add a little bit and probably get Dr. Kunkel to add the end of it. But Lourdes, when you're scheduled in your lab for this test, what are the common indications they're generally being scheduled for? And then Dr. Kunkel, maybe after Lourdes answers that, you can provide a little bit of guidance how an EGG may change clinical management to, over an array of patients.
So you mean scheduling a patient for this procedure?
Yeah. So Lourdes, when you're scheduled, are they coming in primarily for abdominal pain, nausea, vomiting?
Mostly abdominal pain and nausea, vomiting.
Nausea. And Dr. Kunkel, how would those patients, if you got an EGG report, provide some guidance or pearls of wisdom, how for those type of indications, EGG may help clinical manage these patients?
So I think a great example of how it could immediately affect management is if the EGG gives a pattern, a signature pattern, that there's obstruction. That's an actionable finding. And, if we're seeing a patient with nausea, vomiting, and we're seeing this continuous, unrelenting, sort of high amplitude signal that the stomach is trying to empty itself and it's not able to, that informs the plan of care. That makes me wonder, is there a blockage that was missed? Is there pyloric dysfunction? I'm going to pursue that. That's a clue. Generally, though, it provides sort of an opportunity to understand, first off, does this stomach electricity look normal or abnormal? Because if it looks totally normal, then I might be more inclined to treat this in a more traditional disorder of gut-brain interaction sort of family. if we're seeing rhythm instability, we're seeing problems with amplitude, and their underlying risk factors, long-standing diabetes, then that, is going to move me a little bit more towards this is neuromuscular dysfunction, and that'll inform the treatment plan. So, this is a technology that is emerging as we've had larger arrays, as we have automated data processing, as really the science of separating signal from noise has moved very quickly. Because, we're measuring a dim little signal coming from the stomach, which moves around. You've got the heart firing off a powerful signal once a second. You've got your abdominal muscles, that are firing off every time, you giggle. And so that signal to noise ratio is that filtering has moved forward. And so this is emerging as a biomarker that is hopefully going to be connected to therapeutics.
And I'm probably going to ask the next one too, Dr. Kunkel, and probably get both your inputs on here. We got a question from Kara Jets. So first, you, Lourdes, when you have a patient and say they're having tachygastria, a little bit more activity, or bradygastria a little slow, do you see any difference in the patient profile in your lab? And then Dr. Kunkel, to you, could you provide a little bit more detail, like on a normal EGG tracing, what you would look for in cycles per minute or rhythm of that type of nature? First to you, Lourdes.
So during the test, I won't be able to see any tracings because the recording of the data will be done right after the test is completed. So I won't see any tracing when the patient is attached to the array. It's only when the test is completed and I remove the array and the recorder, that's the time it uploads and have the tracings and the data there.
Okay, thank you. And Dr. Kunkel, how when you're looking at them, can you provide a little bit more detail to when you're looking at the tracings from what you look for a normal rhythm to maybe a bradygastria to a tachygastria, maybe some identifiers, patterns of that type of nature?
Yeah, so we do what's called spectral analysis. This is looking for the frequency of this signal arising from the stomach. Normally, the signal fires once every 20 seconds, and that's 0.05 hertz, or 3 counts per minute. So there are a lot of ways this gets sort of jargoned, made very jargony. But we're really looking to see, is there a signal that's in that range? And generally you'd say, okay, maybe it's not right at 3, but it's in a range of 2.65 to 3.35. And if we see a signal there, that's what we like to see. That's the signal for peristalsis in the stomach, and we feel reassured. When that signal is not there very often, then we worry, okay, what's going on? Is there, loss of the interstitial cells of Cajal, for example? Or if that signal is occurring too rapidly, that's what we call tachygastria. So the most basic element of the analysis is frequency analysis, called spectral analysis.
Okay, perfect. Laura, this one's to you. It's from an anonymous attendee, but could you provide the CPT code again for the group?
Okay, it's 91132.
91132. Thank you very much.
You're welcome.
Appreciate that. And Dr. Kunkel, this probably goes to you. It's from Pratik Mathur. how does an EGG test result compare to a gastric emptying study?
Great question, Pratik. So I think, the best analogy is an EKG versus an echocardiogram of the heart. We're looking at different things. The EGG is looking at the electricity. Gastric emptying study is looking at how quickly a particular food test meal leaves the stomach. And so you can have arrhythmias that don't necessarily affect the muscle activity in the stomach. That's possible. You can also have, issues where the electricity is working just fine, but the muscle is impaired. And so the emptying might be impaired, but not necessarily the electrical signal. So these are different tests looking at different aspects of the stomach. And at the end of the day, we're trying to get our patients feeling better, and reliable biomarkers are definitely our friend in this foregut space.
Thank you. And Lourdes, I have another one I wrote down here just for pearls of wisdom to people who want to maybe start doing EGGs in their lab or reconstruct their protocols, or just interested to learn more about it. What pearls of wisdom would you give to when you're trying to, 5 hours is a long period of time and they're looking at a little antsy, you want to go in that type of stuff like that, maybe feeling a little bit of a back pain, sitting in a hospital bed type thing. So what pearls of wisdom do you get to ensure the patient that, we're going to work through this as a partnership, we're going to be a team here? So what pearls of wisdom, maybe sayings or advice do you give the patients undergoing this procedure?
Usually what I tell them, I reposition them, make sure before I start the recording, I make sure that they're repositioned comfortably, if they're comfortable that way, if I need to put the pillows under the back, because I tell them that if you have less movement, it would be a better result. Continuous movement will alter the result of your test. Or I encourage them to go bathroom before we even set them up, because going to the bathroom, those iPad that they have beeps, because like they would say, oh, you're moving too much. It reminds them to, if they move too much. And sometimes they call me like, oh, my back's hurting. I've been on this position. I said, okay, let me help you. Don't move too much. I'll help you move you, or put a pillow under, or what do you want me to do? So the thing is to make sure that their legs are relaxed, so that the abdomen doesn't contract and the abdomen is relaxed. So they're always in a certain position that the abdomen is relaxed. It's either I put a pillow under their legs and just help them reposition by not moving too much.
Perfect. Appreciate that. And I just want to mention the billing codes for this is also on the ANMS website under resources. If patient attendees have joined us late about the billing codes, they're also on the ANMS website under resources. I got a question for both of you kind of on this. We talked about the 5-hour study. So first, you, Lourdes, when you give the stimulation, the meal, the bar, whatever that may be, do patients are they instructed? And is it important for them to complete the entire drink or bar?
Yeah.
And Dr. Kunkel, to you after from Lourdes is, what advice would you give why you do a 5-hour study when you're only looking for a normal 3 cycles per minute, and a diagnosis after the stimulation 30 minutes after, for the reasoning maybe for potential why the 5-hour test? First, you, Lourdes, how do you do that?
Okay, so that's one of the instructions I gave them when I called them a week before the procedure. So I tell them step to step what to expect. I tell them that they will be given a meal, and I always ask them if they have any dietary restrictions, so we will be able to provide them the correct meal that they can eat, because there's like patients who are vegan and they cannot, eat certain food. So I tell them all these steps, and I tell them all the necessary thing they need to know so that they know what to expect. So when they come and do the procedure, they don't even have any questions for me. I said, before we start, do you have any questions? I already spoke to you ahead of time. So they're already ready. They know what's gonna happen. They know that they have to eat the meal, because I tell them the week before that you will be given a meal and it will take you only 10 minutes. They give you 10 minutes to eat it. And I encourage you to finish the whole meal so that you will have a good result on your test.
Thank you. And Dr. Kunkel, a 5-hour study is a little bit of a long time, but why would you do that when you're only looking for, a normal for 3 cycles per minute during a study, and a diagnosis potentially 30 minutes after the stimulation meal? Can you provide some guidance for the attendees regarding that question?
Yeah, so over the years, and EGG has been around for decades and decades. There have been a lot of different protocols. And so why is this system calling for a 5-hour protocol? Well, clearly what's emerged, we're trying to get EGG more front and center in our clinical practice and not just reserved in the research area. And so we have bigger arrays, we have more data, more data analysis. And when you have a patient there for 5 hours, as I said earlier, one of the key things is symptom association analysis. So you're getting a lot more symptom data than just in a 30-minute pre-meal, 30-minute post-meal window. We also clearly know that this signal can be affected by BMI. And so if there's more distance between the electrode arrays and the organ that's being measured, you probably want to have a little bit more sample size to really appreciate that signal to noise ratio. 5 hours is all right, that's something we can do in a clinic, as Lourdes knows, where the clinics are open for more than 5 hours. So it's a doable time frame. But there are ambulatory protocols out there where, systems that patients wear and come back a day later. So 5 hours is for this system in its current setup, but it's a moving target. And I would say globally, with this technology, what we've seen is more data is better, and we're trying to make this more clinically relevant. So that's why the protocols generally are going to be longer now than they were in the 1980s, for example.
Yeah, I think that makes sense. When I first started doing it, it was much more truncated, right? It was very quick, and that point. And I think what Lourdes said before this is really important. And I think setting the right expectation, like Lourdes says, she calls the patient, gives all the expectations of what is going to occur during the test, because finishing a meal in a very specific time frame is critical to this test. You don't want people drinking the meal for 30 minutes and nursing it in a lot of ways. So setting those expectations, if anybody's starting to want to do this test or bringing it in their practice, setting those expectations to the patients, I think is very important, especially having them to complete the entire, because as Lourdes talked about in her presentation, there's a specific caloric intake, and from a physiology standpoint, that is really impactful of the gastric physiology. So we're running at the last couple minutes. I got just one more quick question for Lourdes, and then all the other questions we haven't been able to get after the call we can respond to them on Doc Matters. And Dr. Kunkel, myself, and Lourdes will work through the ones that we don't get. But Lourdes, one more thing to you. If you were going to give me one advice, or someone listening, and they wanted to start doing this in their lab, what would you tell that person, the first thing that you would have them start doing?
Okay, so before we start this study, or the EEG options that we had, so we were given an app they give us a step on how to do this test. And then they specifically, when we got the test, somebody from the company came to give us an orientation on how to do this test. So it was really very helpful, because they are always, like, if I have questions, they are always available. I have a certain person that I have in contact, just in case during the test I have issues. Like, the most important thing though is the prep. When you're cleaning the abdomen, doing the exfoliation of the skin, because each patient has different type of skin.
Mm-hmm.
So even if how good you do the skin prep, and this company like have an array, and which is attached to an iPad. Once you put the array on the abdomen, it tells you how the conductivity of the array is. It tells you whether it's marginal, it's poor, and then if it's really minimal. So the best thing is to do the prep well, and be able to see if when you prep the patient and it's done and you're ready and it tells you that you're marginal, then you go ahead, continue the procedure. But there are times that the patient's skin is totally different. It's hard. I have to, like, there are times I have to do the prep twice. I have to remove the array, put another one. So it's very essential. The prep is essential for this test.
I would agree with you. And Dr. Kunkel, any last thoughts, pearls of wisdom to the attendees as we close out for tonight?
One thing you want to keep in mind is payer coverage. Okay, so that's an important consideration with any technology. Here at UC San Diego, we don't order a test unless we have it authorized. Authorization isn't a guarantee of payment, but at least it's a good start. And that's a moving target with this technology, but have that in mind. You know, you want to make sure when you offer a study that you understand the implications financially for your patient population. And we're hoping for more payer coverage, but that we're still, I think, in the early phase of that.
Okay. Well, thank you for everybody joining. These were some great questions. I think the dialogue was fantastic. Thank you, Dr. Kunkel, for your expertise and advice on this. Technology has made, big changes, at least over the last 2.5 decades that I've been around. Lourdes, thank you for your time and your presentation of demonstrating what to do, how to do it, and the pearls of wisdom if someone wants to redesign or implement it in their practice. Dr. Brucha, thank you for your leadership and your guidance and your kind words prior to the presentation. We would like to thank everybody. And Dr. Brucha, do you have any closing thoughts at all before we close the evening?
Just thank you very much, all of you, for doing this, to the attendees for being part of the symposium. If you are not ANMS members, you may want to join the society. We'd encourage you to do so, because it's truly a bottoms-up society. It's if and for and by the members. So you all make the society what it is, and we'd encourage you to join it, and be grateful if you did so. Thank you.
Yeah. Thank you, everybody. Thank you for those
Thank
kind
you.
words, Dr. Birch. I totally actively agree
Thank
with you on that for sure. And everybody join ANMS. It's the greatest society out there, at least in my opinion.
Thank you.
All right.
Thanks a lot.
Thank
Have a good
you.
evening.
Bye-bye.